Hey
Surprise.
man, can you hear me?
Yeah, I hear you. What's going on?
Not much. Just trying to make sure everything is set up and working right.
Looks good. Looks good. You cut your beard back a little bit, huh?
Yeah, yeah.
Because your profile pictures got a nice prominent beard on it. I thought some of the photos of you just in Brazil, right?
Yeah. I was just down in Brazil, and then before that I was in Germany. And but yeah, I'm home for the day, and then I'll head out tomorrow.
Again? What?
Yeah, I've been on the road way too much this year. I'll have been on the road about 300 nights, throughout this entire year. So yeah,
300
that's been
nights. Did I hear that correctly?
what's that?
Did you say 300 nights? Did I hear that correctly?
Yeah. Yeah, it's been a lot this year. Uh typical day's been I'll get home and essentially get to change the suitcase out, wash some clothes, and then have to head back out.
Head
So
back out.
yeah, I mean it's getting towards the end of the year, so hopefully get through the rest of this year, and then next year toning down the travel a little bit.
Sure, that's what they all say. That's what they all, and then all of a sudden that gets booked and this gets scheduled. I know how it goes.
Well, I've actually turned down a number of things for next year already that normally, I wouldn't have turned down. So
Hmm.
yeah, this year was just kind of a lot. So yeah, I'll definitely need to do a little bit less.
So you just came back from Brazil, right?
Yeah, uh,
And
we were
how many
down in
days?
Brazil all last week. Came back on, uh, I don't know, Friday, I think, or Friday, sometime Friday.
Yeah, yeah. Gotcha. Sometime Friday. So that's pretty nice. And then you said you were just down there for it was just 1 week?
Yeah, we did a live patient course. It was me and uh, Alex Wynn, Dave Zelig, Alex Marquez. We were down there for the week. It was a pretty busy week. Uh, I don't know. Normally, I mean, I've done a lot of those courses, but this one really wore us all out. I mean, all the cases were big cases, and every single case was a quad, transnasals, not easy cases. And I mean, we were going, all day, into the night, and, then get to go eat, go to sleep, and then go back right to it the next day. So, I mean, everybody was beat. I thought some of the course attendees were going to tap out, but they all motored through. So it was good.
And it was Monday through Friday or Monday through Thursday? Like what were the days that
Um,
you actually
let's see. Yeah, Monday we did like a lecture recap, just kind of review, all the, here's how you do the surgeries, here's, step by step, did some model review. And then the next, Tuesday, Wednesday, Thursday, they were, seeing patients, one in the morning, one in the afternoon. And then, some of us left, midnight on Thursday, or, some people left on Friday, but yeah, we were there pretty much the whole week, and it was busy. And I flew there straight from Germany because I was in Germany the week prior to that, so I was already a little bit wore out just from doing that. But
Right. What were we doing over in Germany? What was going on over there?
we did with Norris Medical did there was it was like a triple thing. We did started doing a thing in Cologne and did some didactic stuff, and then cadavers, and then that was really nice. They had a really nice facility over there, and then went back to Frankfurt, and Frankfurt did another lecture and model session, and then hopped on a plane and went straight over to Brazil. So it was I just took a carry on, so I had to pack
Just
cold
a carry
stuff.
on?
Yeah, I try not to I get luggage. I've had it lost enough to where if it's something like
Mm.
that, I'm just you know packing it really tight, and so I don't have to check it in. And I was able to. I mean, it's lots of scrubs and stuff, so you could pack them all really tight. And then I travel so much. You know, uh, I bought this book by Marie Kondo. She talks about part of the book is talk about how to fold clothes. So she teaches you how to fold it all nice and tight, and you could pack everything really, uh, economically, so you could squeeze it all in. And yeah, I literally had to sit on the suitcase, but I was able to get it there. The hardest part was, Germany was cold,
Mm.
and then Brazil was warm, and I don't know, traveled so much now, thinking centigrade. A lot of these travels. So Germany was, I don't know, like 3 centigrade or something, and then Brazil, it was in the 30s, centigrade. So it was
The opposite,
it,
yeah.
it cold, and you had hot, and so packing for both of those in the bag, but was able to fit it. Now, where are you located at?
Yeah. That's got to be a shock to your body. I'm in New York, so actually it's been very cold here. It's got very cold here very early this year, very unusually early.
Are you in
But
the city or?
I'm about an hour and a half out on Long Island, so in Smithtown. It's a little town, like yeah, about like hour and a half away from Manhattan.
Okay. I've been
Yeah.
out to Long Island a few times.
Montauk?
No. Probably gonna say it wrong, but Hopog or
No way, Hopog. That's one town south of me in Smithtown. Yeah, yeah.
okay. Yeah, I went there. I don't know, a few years back. It was cold and snow, and
Yep. Where are you located? Where do you live?
I live in Austin, Texas. It's fairly nice right now. I mean, it's cold, but not that bad.
I went to Austin, Texas a year and a half ago for a bachelor party. Loved it. I really, really enjoyed Austin. I gotta say, the beers you get. Do you drink beers at all? I'm curious. I love the beers down there.
You know, not as much as in the past. The older I get, the less the beer seems to like me. It's just, I don't know, it's the carbonation or something. If I drink beer, I just feel bloated. And so usually I'll just drink, something, usually whiskey or bourbon or, I don't know. Actually, there was a surgeon up in New York, Tony Del Vecchio. He got me turned on to Vesper martinis. So I tend to seem to get those usually, but found you can't order those over in Europe. They different type of drink there compared to here in the US. Depending what part of the world you're in, you seem like
True,
you have to
true.
order different types of drinks.
True, true, true. So wait, let me just give you a quick little introduction. I want to share you because you can clarify anything here in case I missed it. So actually, I just Googled you to see what comes up to, and you got your author pictures here. You got right here because you are a world-renowned dental implant surgeon, which is correct. But I love your logo too. I just wanted to show viewers and everything. Um, I want to kind of like break it down from the beginning. I mean, you've been in the implant game for a very long time. You've written a lot of works on what you do and everything. And so now you spend a lot of your time traveling around. You said 300 days or more of this year. So you're only in your house in Austin, Texas 50 roughly 50 days a year. Is that right?
Well, I mean, this year was pretty abnormal. I mean, I've been on the road a lot for the past 5 years. I had a full arch practice for a long time, and I sold it. It's been 5 years now. And, it was probably one of the first full arch practices to sell. And before, I used to tell a joke that having a full arch practice was like finding a kilo of Coke in the street. It's technically worth a lot of money if you could sell it. And not that long ago, a full arch practice, no one knew what to do with them.
What do you do with it? Yeah, yeah.
I mean, you couldn't, they generated a lot of revenue, but you couldn't sell them because the DSOs didn't know what to do with them. It didn't fit their model. You couldn't sell it to an individual doctor because the numbers weren't in the bank's, magic box. And so they were just these aardvark type clinics. And no one really knew what to do with them. I had private equity come by and I had DSOs come by, and, other than Clear Choice, there weren't a whole lot of fixed arch dedicated clinics at that time. So in any event, about 5 years ago, a corporation bought my clinic and bought it to hire me on as, one of their chief clinical officers. They wanted to grow their fixed arch in the company. So then I was doing, executive work, traveling around, quite a bit for that. So, I was still traveling a lot, not as much as this year, but So yeah, I'd say probably, the last 5 years have been, a lot of travel. And, I've kept American Airlines happy and Marriott happy and National happy. Um, but yeah, this year was the most. You Next year, definitely looking to cut it back a little bit.
Could I ask you something, or are you happy?
Am I happy? Well,
Yeah,
yeah,
that's a lot.
it's a lot. I like traveling. I like meeting people, talking to people. I like going in their practices and helping them. But it's a lot to be away from home.
Yeah, you're not a ping pong ball. You're not a ping pong ball. Like you're going back and forth, 300 days of the year. You just did basically a month because you were in Germany and then Brazil, and yeah, it's a lot. It's super impressive, and you've been doing that. It sounds like ramping up over the last 5 years.
Yes, it's been increasing. But again, with everything, there's a goal in mind, and the goal's been do this. Uh, so you don't have to do it for a long
Forever.
time.
Yeah.
So there's a lot of docs. They're working into their 70s plus, and some do it because they like to. Some do it because they have to.
Yeah.
You know, I've always lived pretty frugally, so and have been fortunate to sell multiple different types of practices, and so the goal is to not be doing this into the 70s for sure.
I mean, after do you think you had to was that the is that what the goal was after you sold the practice? Do you think that was on the horizon where you're going to have to work as a clinician until 70s, or you knew the
No,
whole time you were going to transition to mentorship, to teaching, to traveling, to working your way up as you're an executive in the it's the DSO like you mentioned, right? Are you still with them? Is it a different institution now, organization?
no, I did that for 4 years, and then this past year left the organization, and that's where this year I was doing the more private mentoring and then lecturing. This next year, I'll be probably cutting back a lot of the private mentoring and doing more just stuff with some implant companies. Specifically, I do a lot of work with Norse Medical, and we have a lot of events planned for 2026. You know, Teaching events, cadaver courses, live patients, courses down in Brazil and Panama, and then a number of international things over in Germany and India, Poland, possibly a few other international venues. And then usually if I do get into the clinic, it's typically to either do demo surgeries or clean up cases, where there's been, say, failing zygos, or just a case maybe somebody doesn't really want to do, like maybe it's typically quads or something like that. I guess I'd say I'm fairly pigeonholed at this point where, no one really calls me in to do a mandible or a single unit implant or anything else like that. I basically go do quad zygos or rescue zygo cases, and that's about it, which that's just life takes you where it's going to take you. And that's kind of where it is currently.
With the Zygos, is it your favorite? Because you mentioned transnasal. I'm sure you do pterygoids. Like, what's kind of your favorite, at least for right now? And I'm not gonna. And then I want to ask you, how did you get to this point? Also, if we could kind of give a little trajectory here, if we're going in hindsight. And I know some of the story, right? But I want to fill in the pieces, and then also for listeners,
In terms of implants, there's always this saying, the best zygo is one you don't have to place. And, I don't entirely agree with that. I think, if you need a zygo, place a zygo. We've got, again, 40 years of research on zygos. We know all the good, bad, and ugly about zygos. And, I think there's definitely a lot of improper case selection right now. I mean, there's definitely a lot of zygo happy people. But I think when you're looking at these cases, it depends on your mindset and your practice philosophy of, again, if you can squeeze a tiny implant into a spot, it's like, yeah, I could squeeze that implant in there, but is it going to last? And if it doesn't last, who's going to pay for it to redo the case, even if it's, 5 years from now? Are you going to eat the cost and redo it yourself? Are you going to have the patient pay for it? Which, if it's 5 years later, they're probably not going to want to do that. And so, this is where you get really into, a lot of academic discussion of, do I do it now or do I do it later? And then also, you have to take the patient's personal circumstances into consideration. How old are they? If you got a patient that's 40 versus a patient that's, in their late 60s, that's probably going to change your thought process on them. Hygiene, why did they become in the situation that they're in? I mean, I'd still say for me, I like Zygos a lot. I like pterygoids. I wrote the textbook on pterygoids, and I like pterygoids a lot. I think, if you had to ask me what my favorite implant to do is, I would say, Zygo for sure, just because I think they can take a lot of patients that don't really have many other options and get them a set of teeth to chew again. A pterygoid can help with that, but it can't quite do all the heavy lifting a Zygo can do. And then, now we also have custom subs entering the picture. And, to be perfectly honest, I've never done a custom sub. I don't have anything against custom subs. I think there definitely needs to be more research behind it. We have all the research from the 70s on the old, traditional subs. The new custom ones, the biggest issue I see with them is just there's really no standardization of them. You have, a bunch of different manufacturers, labs making them. There's no real standardized design protocol. Where do you put the struts? Where do you put supports? How thick does it need to be? At some point in time, there might be a standardization of it, but you may do the surgery perfect, but the design was bad. And unless you are, in the process of doing the design of the sub, which some people are, you do give up, I think, some control over it if you're just accepting it from the lab or from the manufacturer, just because a lot of the success of that rides on the design where, the Zygo, and there's differences of the Zygo, but, it's the same thing. Essentially, it's a screw, it's a long screw, same diameter, same length, variations in geometry, things like that. But, at the end of the day, it's a screw. It doesn't matter what manufacturer you get it from, but subs are, very, very different depending on, manufacturer A, manufacturer B, manufacturer C. You got to take it all into consideration. I mean, what do you think? I mean, what are your thoughts on subs and Zygos and transnasals, and you got one that's your favorite?
I really did like the IPS systems, the subperiosteal. I thought that was a great replacement for zygomatic implants. I really did. I did a handful of them in residency. Haven't done them since. Just finding the right patient fit for that is very, very difficult, at least in the private practice I'm in. But nonetheless, I didn't get to see them long term though. The most I saw was maybe several months tops. And then you want to keep everything as close to the bone as possible. But anything that goes a little too far, or like the pegs stick too far down, they end up with mucositis and the whole thing could, go to shit. But I think it's a great thing that we're looking into right now. But you hit it on the nail on the head, where you need to be involved with the design, because a lot of people making the designs might not, they didn't do the surgery. And where does everything go? How many screws are you going to put?
Yeah, and I would just like to see more. I'd just like to see more follow up, and what what happens when things do go bad. I mean, we'd see plenty of successful cases being shown. We don't really see tons of the the bad and the ugly being shown, and we see tons of that being shown with Zygos. I think a lot for the dramatic effect, because you have big implants, big problems. But on the sub side, I just would like to see just some more published data. And if the long-term published data shows that they are working better than Zygos, they have less complications than Zygos, then, by all means, I would see you probably going to have a shift towards that. But, you know, at this point in time, there's some study. I mean, there's definitely not as much as Zygo. I mean, Zygo's got a giant head start on them. But yeah, if we keep seeing, more and more publications come out, just the more they come out, the more credibility it has, the more, we know how to work with those types of restorations and procedures. I just would, like to see more and more lit come out on that so we could, have it to fall back on. And, especially with the society as litigious as it is. And, I get asked to be expert witness in, a number of cases. And, I would just say, like, for example, if you had a case come in and if you don't do a lot of subs, say you did a sub for this case and something goes wrong with it, if I'm on the opposing side, I'm going to be telling as the, expert clinician, I'm going to be talking to the lawyer and say, all right, well, you need to hammer this guy. And, how many of these has he done? If this is, his first one, or I don't know, maybe he's done 3 or 4 or whatever. And you're like, okay, well, doctor, why did you decide to pick this one as opposed to, say a Zygo? You could have done a Zygo here. Why didn't you do a Zygo? And, and then you start bringing lit into it and you're like, okay, well, there's 40 years of lit behind Zygos. It's a proven technique. This technique, it has lit, but definitely nowhere near the Zygo. Just please, doctor, explain to me, why did you choose this over that? And if you could back up your position, that's cool. But, I think with the Zygo, it's a lot easier because there's just thousands of articles. We can use it to support pretty much everything. We know everything that can go good, bad, sideways, whatever with the Zygo. And, there's not as much on a sub. So, if you get someone that really knows what they're doing, in a arbitration or whatever courtroom, they could use that to their advantage or use it to your disadvantage. Just the amount of lit that's out there. I would highly encourage the guys that are doing subs, keep publishing the lit, keep, putting that out there because it's only going to help things, for the profession.
Yeah, certainly will. I agree. Yeah, we got to get there. We need a lot more cases to do, and the people doing the cases, like you said, they got to be publishing on it.
Yeah,
and I think a lot of residencies are. Yeah,
and I think doing them. Yeah, a lot of people ask, what do you think the next frontier is for, implants? And I'd say, for the maxilla, it seems like, I don't know, it seems like we've done almost everything possible in the maxilla. I don't know, there might be more stuff that don't know about. I can't really think of any. It seems like these really atrophic mandibles are probably the next type of frontier of, what do you do with these cases where you're ideally not going to graft them, really custom subs, kind of shine in that area. So, that could be the next thing we see in the upcoming few years of these custom subs for the really atrophic mandible. So
that could be it. That could be it. Yeah, we got to see that's really new. The one I didn't get to do any mandibles in residency. That's a really new one. But yeah, we're getting there, and it's nice to see some new products come out. Unfortunately, I don't know. I like the U.S. I like to see research coming out of the U.S., but it came out of Germany, right? I think it was KLS was the one that really started to bring the subparietal implants over here.
Yeah, you got that and Bone Easy, and there's a number of other ones. And talk to our colleagues over in Europe, and I think they definitely have the advantage over us in terms of cost, where these definitely have a much lower cost compared to what we get them for here in the US. I think that's also a little bit of a barrier for sure right now, where you could do a Zygo or a bull or a pterygoid for a fraction of the cost of what it is to get a custom sub, at least in the US. But it sounds like over in Europe, the price point's definitely much more favorable. So I would imagine it's going to be just a matter of time before it gets like that, here across the pond.
Yeah, that'd be nice. Across the pond. What are one of the issues we had? Both for subs and Zygos in residency is not issues, but I think getting access to very lateral on the zygomas. I thought I'd ask, do you have any special techniques or anything, or it's like, don't forget to do this because that's how you release and get this much more visualization and access? If you had anything recommendations off the top of your head.
Yeah, I'd say that's probably when we're teaching these, probably one of the biggest issues is just docs having enough flap reflection.
Yeah.
And I think, the flap design, some docs don't do any vertical releases and some do. Like, I'll typically do a vertical release, at the midline.
Midline, yeah.
Then I'll do another pair of vertical releases just slightly posterior to the zygomatic buttress. And some docs don't do that posterior release. And I find, at least for me, it makes it a lot easier to have access. And when we're teaching these courses and working with docs on these, I'll go through a certain number of landmarks and I'll teach them, if they do a good flap reflection, they should be able to just use a Minnesota. And after the flap reflection is finished, if you do a good flap reflection, you should be able to hold the Minnesota with literally just one finger, or a thumb. That's it.
Yeah.
And if you have, there's probably, I don't know, a good half dozen Zygo retractors in the market. And some of them, have a little hook on them. Some, they have handles. And what I find on some of them, people can cheat and they can, shove that retractor up through the soft tissue and it will hook, the zygomatic arch. And, they kind of use that as their hallmark of, my dissection was good because look, I hooked into the notch. And if I can hook into the notch, I'm in the right spot. Well, you can still have a crappy flap reflection, shove that retractor through the soft tissue, it hooks in the notch. You still can't see what you need to see. You can't really do that with the Minnesota. So, we'll teach that, do the flap reflection. And then when you finish, you should be able to have identified, the hamular notch, the masseteric tendon, the nasal mucosa, the infraorbital nerve, and the orbital rim. So if I can identify all of those things, and I'll put all those in the notes. So if anyone ever reads the note, they know that must have had a good flap reflection if you could see all those things. And then you should be able to slide the Minnesota, all the way to the lateral portion of the zygo. Typically we'll go from about, the height of contour of the zygo, about a centimeter, posterior to that. So if you can do that, you can use the Minnesota, you can see everything you need to see. I don't know how else to describe it other than you can also get a feel for the way the flap feels. So a lot of them, I'll go check the flap and I can already tell without even looking at it, just the way the flap feels, if the retraction's enough. And when it isn't, I'll have the doc like, okay, come feel this flap. And then we're going to go reflect a little bit and then feel the flap. And they'll feel it's much looser. And one other thing that seems to help a lot is take a finger, put it on the orbital rim, another on the base of the zygo, and then basically take, like an overhand grip. And, I call it the windshield wiper. I have typically like a 9 mult and I just will go between my finger and my thumb. So I'm protecting the orbit, I'm protecting the infratemporal fossa, and then just, windshield wiper. And it slides back around the curvature and will get you back there really quickly. And
seems way back there.
Yeah, you're pretty much lateral. You're at the lateral canthus, and I think that is much more than what a lot of docs expect. But once they see it, they can see how much better they can see, and especially with the Zygo, being able to see makes a lot of risk go away, because if you can see everything you need to see and mark everything out with your pencil, like for me, that's probably one of the biggest changes in the past few years is, I definitely mark everything with a pencil. Whereas in the past, you just kind of eyeballed it, you're looking at it and you're just like, okay, that looks good. My angle should be right. And, now, we teach you draw everything out with the pencil, build in some safety parameters. And then as long as you follow your lines, it should be very safe, and you should, end up where you're supposed to end up. And, in teaching this to the masses per se. This is the most, at least what I found, reproducible way, because if you make lines and you follow the lines, you have something to look at. If you have landmarks you're basing those lines off of, you can repeat that on other patients.
Yeah.
That's if you're just watching somebody do it, you could watch them 1,000 times, but if you don't know exactly the step by step what they're doing, you kind of have an idea what they're doing, but it's less repeatable.
Yeah, replicatable. You can't replicate as well unless you, yeah.
Yeah.
It's a really good point. You just started recently outlining everything with the pencil, you're saying? So you're saying after you reflect everything, you got to suction out of the way and then you mark it on like the zygoma and everything with the pencil, or you're just saying like on a separate model?
No, with a pencil, in the mouth on the
Yeah,
bone.
intraoperatively. Yeah.
I don't know. I've probably been doing that for at least, last few years at least. We used to do it with a little golf pencil. Now I don't recommend a golf pencil because if you're doing a quad, you got that little tiny pencil, and you usually end up having to, hold the pencil by the tip and you're reaching. You just get a big long pencil, sterilize it, use it once, and then toss it. Sometimes we see offices and you're using the same pencil 5-6 times and the paint starts falling off the pencil, and some of the pencils turn into rubber, and you can bend them, and or they dry out and crumble, and it's just use it once, toss it. It's a pencil. It's like
a pencil. It's a pencil.
it's 10 cents or something like that. But the long pencil definitely makes it easier to reach way back there, because it's like working in a little cave. It's way back up in here. Having
you get access through the mouth. Yeah, that tiny little area for sure.
Yeah. But that for sure is, I'd say, probably become one of the most important tools is just a sterile pencil, man.
Yeah.
It's made things definitely much easier for sure.
So for listeners, get yourself a good old Ticonderoga pencil. Do you remember the Ticonderogas? No, the one with the green handwriting on it. No.
Yeah, no, those were great.
Yeah, those are the best.
Something that writes, and
yeah,
it was funny because we were down in Brazil. I don't know if they have different pencils or what, but we had these pencils, and they didn't write like American pencils. Maybe it's different graphite or something. I don't know, but whatever it is, as long as you can see it,
In Brazil, were they under anesthesia? They had to be, right? They were under GA?
Yeah. So at this particular course, they were under IV sedation.
Just okay, IV sedation. Yeah.
Yeah,
so not full on. Were they intubated?
No, they were not intubated.
Okay. Yeah.
When you're doing these courses overseas, it's really a grab bag of what you're gonna get. I mean, we've done these under local. We've done them under oral sedation, IV sedation. At this point, I would either rather typically have the patients under full general or basically awake. You hate to say like under local, but if you have good pain control and the patient knows what to expect, you can definitely do these under local. Sometimes under the IV sedation, sometimes the patient's a little bit less cooperative. General is definitely the nicest way to go, but that just depends on your state, what the regulations are. I know some states, even to do GA in the office is really cumbersome, because essentially your office has to be certified almost to the level of a hospital. It's not necessarily the matter of is the doctor qualified, is your facility certified. Right. And that varies so much by state to state. And I know some docs, they're like, hey, look, I'd love to do it. I just, have to go through all the regulation process of getting the office certified. And, I've been in some offices where I don't know all the state regulations, but they're telling me, they've got to have positive pressure in the room. They've got to have all kinds of crazy stuff that in other states you don't have to have. So, it's so highly varied everywhere. General's very nice. It is safe for the patients, good for the doctor. Yeah, I would definitely prefer that for sure.
Right. Being that you've done it under sedation, you've done it under GA, you've done it on a bunch of trips. I mean, for years, and your own cases too. What's one of the craziest complications or you've seen, whether it be intraoperatively or before we get to zygomatic implants, because I've seen so many where obviously, you get the little fistula, or, it goes through the skin over here. I've seen those cases, but also into the orbit going up there.
Yeah, I mean, for Zygos, I mean, I've seen some pretty nasty, cutaneous fistulas, and those, I think those we tend to see a little bit more now. And I think one of the reasons we're seeing this little uptick in them is obviously one, there's more people doing these cases,
Yeah.
all kinds of different skill levels. But two, I think that, some docs are over prepping and getting into the dermal tissue. And, one, if your retraction isn't good, if your reflection's not good on your flap, if you can't see where the tip is, then you have a good chance of missing your retractor and drilling into the tissue. And sometimes, especially on a quad, the anterior implant, it's up around the corner. You can still have a good, very adequate flap reflection. It's just you're having to look around a corner, and it's hard to see around a corner. And so, if you're doing a retractor where you are just holding a handle right up here, if you didn't see that drill tip and you miss the end of the retractor, I've seen guys, they're drilling to 60 millimeters, and then we go take a measurement, and when it's measuring at 50, so we know that they had to over drill by 10 millimeters. They didn't feel it pop through the bone. They didn't feel it vibrating on the retractor. And that's one of the other reasons I like the Minnesota is we'll teach, they're still going to put it way back here. It's got a wider tip than a lot of the retractors. And also, if you can hold it with one finger, you can put your fingers on the skin. So, now your drill is either going to hit your Minnesota. If it happens to not hit the tip of the Minnesota, when it perforates the cortex, you'll feel the vibration under the skin. So now you know to stop. And, I think some of these docs are, over prepping, drilling into the dermal tissue. They can't keep the bone adequately cooled. They don't have, irrigation up there. So those things, I think are contributing to that. And, those are pretty nasty to deal with. I definitely have seen drills and orbits, and knock on wood, fortunately, you haven't really seen any sequelae from that. Haven't really seen any damage to muscles of the orbit. No strabismus. Definitely no damage to the globe or anything like that. The way that we'll teach this is. The way I'll teach it, at least, is when we make the marks, we'll find the rim of the orbit, the crest, and make a mark about 2 millimeters below that crest. So that's going to build in a little safety margin for the dip in the floor of the orbit. And then when we're drilling, we'll drill 50% of the way. And then I'll have the docs take a probe and feel the roof of the prep. And I call it a sunroof check, because basically the roof should be solid.
Yeah.
If you got a hole in the roof, you're in orbit. And so we'll drill 50% of the way, do a sunroof check. Then we'll drill 75% of the way, do another sunroof check. And, if it's solid, you're good. Now you can finish drilling, and you're not in the orbit. And if you did happen to perf into the orbit, because you're only going halfway and then 3/4 of the way, your perf should be minor. If you've mapped everything out with a pencil, you've built in this 2 millimeter safety margin. Typically, we see people enter the orbit. It's usually because they're not following the line exactly, or the osteotomy entrance point has a little, bony shelf, and it's kicking the drill one direction or another. If they do happen to perf into the orbit, following those little steps, it makes it, a minor perf. It's not typically causing any type of issue. It's definitely much safer than, just going to town and drilling, until you pop through. I think building in all those little checks and balances and safety measures make it a more predictable and safe procedure, because you're not always going to have somebody there over your shoulder when you leave these courses. And if you have this checklist of things to go through, it just makes it safer, and then should hopefully give you a lot more confidence when you're doing it on your own.
Right. You follow those steps and you can keep yourself in check, stay in the lane. Yeah.
Yeah. And we had complication lectures, and uh, honestly, it's funny because pterygoids get this really, really bad rap. And believe me, when I first did pterygoids, there were no classes, there were no books. I mean, there was no nothing. I mean, I
Yeah.
just did a lit search, read it, and said I'll give this a try. And the first pterygoid I did, I always tell this joke: if you put a piece of coal in my ass, it would have turned into a diamond. Because I was terrified. And I didn't have anyone there to guide me or anything. And now, fast forward all these years later, and we know there's, I mean, honestly, I mean, you need to respect it. But if you follow all of the landmarks, I mean, pterygoid is actually a very safe implant. I mean, you got the pterygoid plexus, but you really have to be, you know, going to New York, but end up in Connecticut, or something. I mean, you really have to be off to hit that thing. And we'll teach, when we're doing a pterygoid, one of the landmarks is, when we're drilling, we're using osteotome. If you're looking outside the mouth and you follow the angle of that drill or osteotome, it should cross essentially the bridge of the nose to almost the medial of the contralateral eye. If you're crossing that, it's impossible to hit the pterygoid plexus. I mean, you have to be going to the lateral canthus of the ipsilateral eye, so you're totally going the wrong way. So you take that out, you still could possibly hit the descending palatine.
That's my concern. Yeah. That's a big concern of mine.
And the thing on the descending palatine is, if you look at, I mean, I could tell you this. I've seen dozens and dozens of pterygoid implants that were in the greater palatine canal. And, there was no issue. We know with all the thousands or tens of thousands of pterygoid implants done yearly, those of us in the remote Anchorage world, if there's a bleed, we usually end up hearing about it. I've now heard of two. I've heard of two DPA bleeds, and that's it out of all of these that are done. Definitely we got to respect it and stay away from it. And I know most max faxes have a horror story about a DPA bleed, but they're typically talking about with Laforts.
Laforts, yeah.
I mean, you're doing a big cut with the Lafort. I mean, if you look in the lit and you look at real life, the lit shows there's virtually nothing anywhere in the lit about DPA bleed from dental implants. There's one case report, and even that is fairly dubious, because if you read that article and what they attribute the DPA bleed to doesn't really add up. It was an implant at a first molar site, which is not typically where we're going to see the DPA.
Yeah, that's way off.
And the bleed happened at stage 2 uncovery. And I read that article, I'm just like, and they attribute it to that. And I'm just like, okay, they did digital subtraction angiography and attributed it to changes in the descending palatine. But you read about everything they describe in the article, and I'm just like, well, I don't know if that was actually it. But that's really the only article for dental implants that talks about a DPA issue. And ideally, we don't want to hit any artery at all. So you got that. And then, the other risk was losing the implant, losing it into the sinus or into the infratemporal fossa. Dan Rosen really took care of that problem with his Rosen driver. You can't lose the whole driver. So that really has eliminated that problem. There's, unless you're doing something stupid, like putting a Zygo back in the pterygoid region and drilling into the brain, which, there's a couple case reports of that. But, that implant's really been relegated to a fairly safe implant. Now you go to the other end of the mouth, you get transnasals, and I think we're still early in the game with that. We're still waiting for complications. I've heard of, Vichy Broman, our good colleague down in Phoenix, decided to do, a couple of repairs on the nasolacrimal. But I would venture to say you can get a cutaneous fistula with the Zygo. Stands to reason you get a cutaneous fistula here, if you perforate, the lateral of the nasal wall. So, I'm waiting for that complication to happen. I imagine it probably will at some point. We're just waiting to see, what will transpire, because there's, lots of different possibilities, I guess I would say. I don't think we've seen them
Yeah.
all yet. There's definitely be some shocking Instagram posts or something at some point in the future, I would imagine, when the first cutaneous fistula hits, or,
Yeah.
so I think, in terms of Zygos, we have seen a lot of the complications that can happen with them. But, kind of the most typical thing that we see with them now is oral enteral fistula, sinusitis. All the other stuff is the more extreme, and we certainly see it. But if you're following all the steps and doing everything properly, they really don't have a ton of complications.
Got to follow them properly though, and you need to be well trained. Yeah, like that. You need to go to your courses and have plenty of attention from the instructors. Yeah,
Yeah, yeah. I mean, that's
So
the thing. I
can't
think
just
also,
wing these. Yeah,
you see with the Instagram world, we definitely have people jumping ahead, skipping to the front of the line, I guess you could say.
for sure.
I think that's where maybe you get some issues and complications is, when that happens, uh, I mean, dude, I was in the Navy for 13 years. I remember I did a GPR my first year in, and then got sent out into the fleet at my first duty station. In my first 4 months, all I did was exams. It was like, 40 exams a day, every day. And that's all I did. You got other docs nowadays, day one out of school, they're taking a Zygo class. I think it will come. It's just, it depends. If you were in dental school and you did a bunch of implants and, you had, experience, great. But I would say, take your time, get all the basics under your belt first,
For sure.
learn how to reflect a good flap, learn how to deal with bleeds, know the anatomy. I mean, a lot of docs are doing these, they don't even know some of the anatomy yet.
Yeah.
Get the basics under your belt. And, so then hopefully they don't have complications and have to send them over to someone like you to deal with some of them.
Yeah. Yeah, we've seen a lot of it. Yeah, that's a good point, though. Unfortunately, in dental school, very few implants are being done with the dental students. I mean, maybe the most I heard was maybe 2 throughout the United States. So I'm sure you could have a dental student. I did 3, but I mean, generally they're not doing much. But you're right. A lot of them, they just want to jump to these major surgeries, these complicated surgeries, without having the fundamentals down. How many basic implants have you placed before you try to do a zygomatic implant or a pterygoid or an all-on-X? That's another thing. A lot of students, they just want to jump to these all-on-X procedures without even doing a residency. And you just finished learning how to scale and root plane in dental school to be jumping to these all-on-X's. It's scary, and it's kind of frustrating too, because some people would do residencies, and when you were deployed, you were doing exams when you were out of dental school and residency, right? But there's also the market that we're in, and the insurance squeeze pushes everyone towards, these more reimbursable procedures that are outside of the insurance reimbursement world, and that doesn't necessarily make it safer for the patient.
And I would say it's definitely very admirable. There's a lot of docs that are, every CE course imaginable, they're there. And, they definitely are putting in a lot of time, spending a lot of money, and, I guess getting to focus on what they really like to do and enjoy. I talk to a lot of these docs and I tell them, I'm really envious of them because, as I said, my gosh, when I was your age, again, I was, doing exams. I wasn't even doing anything. You guys, some of these guys are doing, they're doing these big major procedures. I was telling them, like, man, that wasn't even in my brain. It didn't even exist at that point when I was your age. So, good on you for, the fact that you are doing this already, is pretty amazing. And, it just shows you how accelerated, the education process is now, especially with, everything that's available on social media and just, online training, weekend trainings, continuing courses. A lot of these docs are going to courses, every weekend type continuums. So they're, for those docs that didn't, end up doing a residency, some of them, are I think still putting in the effort and spending the money and going to the, different trainings. But, I think it's knowing your own limitations of, what you can and can't do. Some residencies teach certain things and don't teach other things. You may go to, again, even in oral surgery, you might go to one and it's really heavy in trauma, and you're great at trauma, but, maybe you're not getting as much implant experience. Then you could be at another one and it's really heavy into orthodontics. You could be in perio, and some residencies, you can be a badass researcher, but you're not doing a whole lot of actual patient work, but you can quote lit back to 1900, and so every program's, different. You're going to get trained differently everywhere, and so I would just say, recognize your limitations. What did you get training in, and what didn't you, and what do you need work on, and just try not to take on, I don't know, I think also just some of the fear factor is gone. I mean, I remember very specifically at one point in my career saying, I'll never do a Zygo. You'll poke someone's eye out with those things. And I had a great healthy fear and respect of those. And, it took a while to get, past all that. I think it's good to definitely have that fear and respect, and know what you should be afraid of and know what you shouldn't be afraid of. I think that's probably also part of the battle is a lot of docs don't know what they should be afraid of and don't know what they don't need to be afraid of. And that just comes with having more knowledge on this stuff.
More exposure. Yeah. Yeah. Knowledge, exposure, and experience.
Yeah.
100%.
Yeah. I mean, with you doing a podcast, I mean, what do you think tends to be the most popular topics that you have, for the podcast that you see docs want to hear about?
There's a bunch of topics. I mean, it's going to obviously be, pertaining to whoever that I'm chatting with, the speaker, the person. Like for yourself, it's great to get into stuff that you wrote textbooks and chapters on, and that you do on a daily basis. Like we just went through the whole, special landmarks, things to be careful of, how to get to that access. That's one of the things that I was having trouble with in residency is how do you get more access back there so that you can really visualize the zygoma and get a nice zygomatic implant in there. And then how do you prevent it from going into the orbit, or how do you notice if it is going into the orbit before it gets completely in there? Yeah, I mean, that's incredible. People are going to tune into this just to hear that part. You know what I mean? But what are some of the most interesting topics? I mean, it's going to vary. It's going to vary per person. Yeah, we just hit on a bunch, but before we go there, I want to learn some more things about that. So you were 13 years in the Navy, you said, or 15?
Yeah, 13. Yeah.
13. And then what'd you do after that? Because you said you did GPR, then you did 13 in the Navy. 13 is a long time.
Yeah. Well, I joined during dental school, and there's a couple different programs. The one program I was in, the years in school counted it as active duty. And so you were actually enlisted. So you were enlisted on active duty. You didn't get your school paid for. They basically just paid you your Navy salary as, an enlisted, E3 at the time. And ideally you were supposed to take that salary and apply it to pay for school. And, with that particular program, one of the benefits of it was you got health care. So I was married and we had our first child in dental school. So all that was covered by the military, which, even if I was under one of the scholarships, that wouldn't have been covered because you're on inactive reserve. So when you're on active duty, everything's covered, and that was nice. And then I did GPR, and then I was general dentist for 3 years. And then I went to perio training. Then I had to pay that back. And then at that point in time, it was up for promotion to commander. And if you take that promotion, you have to give back time. That would have put me close enough to retirement that you'd be stupid to get out. So it was kind of like, if you take this, you're staying the rest of the time. And, the one downside of the military is you would move a lot. On average, we'd move about every 3 years. And, when you got kids, ideally you'd like them to stay in the same school, because, the problem we would find is as soon as they make their nice friend set, they get comfortable with them. It's time to move again. And then they got to start all over. It's easy to do when they're in elementary school, but when you get to middle school, you get to high school, it's a lot harder to go make friends like that.
Yeah.
So for me, that was the biggest reason for getting out, was just so the kids could be in one set place. So I got out and then found a little perio practice for sale and got that. And I was doing traditional perio, always doing in Austin. I was doing, perio things, GTR bone grafts and, I don't know, osseous and all that kind of stuff. And it was fine. I was doing all on X's, and back in those days, there really weren't that many people doing all on X's. It was still kind of considered, experimental. And you'd walk into a room, there'd be people whispering on the other side of the room because, you were the person that did all on X. And there was really like 3 of us in town that did them on a regular basis way back in the day. Now, everybody does it. Yeah. But, it wasn't like that back then. I really liked it. And, decided I wanted to focus more on that. So then I, had sold the perio practice, and then.
When was this now? Because you started in the perio practice in Austin. When did you sell it and then started the implant center? Just so I could get a timeline.
That was like 2013.
Okay.
So 2013. And, so, at that time, you didn't really have any dedicated implant centers, other than Clear Choice. And, so, it was quite different for the time. And, we were doing things, that are very commonplace now. We were doing, TV advertising and Google and all this stuff, but a lot of it, wasn't really done back then. And then from the full arch practices, we, got into, early digital stuff. And, I think I had the number 2 and 3 Zirconzon mill in the United States. And they literally came and dropped it off in the parking lot in a crate. And we had to hire guys from Jiffy Lube next door to bring it into the office because, they didn't have any white glove service. They literally dropped it off and left.
See you later.
So yeah, we're, figuring all this stuff out. And, that's where I tell a lot of the young guys, I'm also envious of them because, they just have a course, they can go and teach them stuff that, some of the stuff that's a passing comment in a course might have been stuff that we struggled with for a year to figure out what to do, how to
pioneers
deal with it. Like something as simple as a double screw, putting 2 screws in the same access hole. It used to be a giant pain. Now we know, okay, just use this tool and you pop it out. But back then there was no one around to tell you to do that. So you're having to figure it out on your own, which was a monumental, pain in the butt. So I tell some of these guys, I'm like, yeah, that little passing comment there, that really
took
created
years to get to.
a lot of pain. As I have envy some of these things because, it's a lot of it's being handed to you on a platter.
Yeah.
All of this stuff.
But you were there. You helped pioneer that, and these are the things we got to talk about on these podcasts, like to go through the steps and painstaking, to get there, to get to the point, to know that. I'm sure that came out to chapters in textbooks to figure out how to reverse those complications and jimmy the screw out and stuff.
All that stuff. It's I guess there's all growing pains on any time you've got new procedures, new techniques, and it's really amazing all the new stuff that's come out over the past, even 5 years, with the advent of digital and, just the process of, essentially eliminating old school pickups. And I still think it's a good skill to have just in case you ever need to do it. Maybe you can't communicate with the lab. Maybe something goes down, maybe you have software failures, issues, just having that ability to be able to go do it if you needed to, I think still a valuable skill to have out there. But a lot of that stuff's falling by the wayside. you don't even see some of the equipment in the offices anymore. Even if you wanted to do it, you wouldn't have the stuff to do it, um, but it definitely has all the advantages. Speeds the process up, makes it, a lot less painful procedure for everyone involved: lab people, assistants, the doctor, the
Yeah.
patient.
So let's because before we wrap up, I want to get to some personal topics, or if I may, are you still with your wife, and do you live within the same area in the same vicinity as your kids? Are they still in Austin, Texas?
Yeah, yes. Yeah. So we had our 30th anniversary this year. So got married a long time ago.
Congrats!
And
Congratulations!
yeah, thanks. My kids are all grown. My oldest is finishing up CRNA training, and so
Very nice.
she's got herself a job, so she'll be out in the job market earning money. So that's good. My younger one graduated university, and she's be heading off to grad school and doing her thing. No dentists in the family.
You steer them away? Is that why?
No, they just, I mean, they all, they used to come by the office, back in the day, and would play in the chairs and all that kind of stuff. It just wasn't their thing. They just, all kind of go do the stuff that interests them. Yeah. And so, yeah, now that everyone's out of the house and, you know, grown up and, doing their thing, and we had kids early. It's funny. I talked to some other people my age, and they've got kids that are 3 and 4, and they are just kind of getting started. And so I don't know. We could be moving. There's a lot of different things that could be done up in the air. I don't have a practice that is tying me down to anything at the moment. I definitely have plenty of options of what could be done. So
Do you think that?
ideally, hopefully, it would involve a little bit less traveling.
Yeah, yeah. Seriously, I was gonna say you're talking about maybe potentially moving. You've been moving a lot this last year,
Yeah, yeah.
back and forth. I like your sweater too. By the way, I just got to point out it looks like a nice Irish looking,
Um, I
nice
think I got
Irish sweater.
this. I'm pretty positive I got this in Spain.
Spain,
Um,
really? Hmm.
yeah, during this one trip, I got luggage was lost, and
Of course.
and I mean, for the amount of traveling I do, I haven't really had too many luggage issues. But anytime you lose luggage, the airlines think they're doing you a favor by just go buy something. You get to go on a shopping spree, and it's like, well, number one, it's like with the limited time I have, in whatever location I'm at, I don't want to spend it, going to buy clothes.
Yeah.
It's not just clothes. You got to buy everything. You got to buy all this mundane shit. You got to buy underwear, and you got to buy,
Mm.
deodorant, toothbrush, toothpaste, all
Toothbrush.
that kind of stuff. And, so it's not like this exotic shopping trip you get to go do, and then also you can't really go buy exactly what you want to buy because you don't know if they're going to pay you back for everything, so, you're kind of holding back on what you're buying, and, hopefully you're getting your luggage back the next day, but you never know. I mean,
Mm.
so, at this one trip, I literally got my luggage. They have 30 days to get it back to you, right? Or they have to pay you. And I am not exaggerating. I got the luggage back, I think, at 29 day, 23 hours and like 48 minutes. I think they literally had 12 minutes. This courier knocks on the door at, I don't know, 10 o'clock at night and has the bag. And it's covered in dust. So it's obviously been sitting in some warehouse somewhere. And you had no clothes for that trip. And but in any event, yeah, that's pretty positive. I picked this thing up in Spain during one of those episodes.
Man, I'm sure you have a lot of bags here, bags there. You're waiting on it. I love this. Is this your logo in the back here? You have a couple logos. Did you design this?
Yeah, so this was actually the logo. So this is a funny story. There's always stories behind something. So this logo was for the implant center, right? And so when I had expanded, I had was expanding to San Antonio because I had the practice in Austin. And when I'd have private equity and these other groups come by, one of their biggest issues was, well, maybe this only works because of you. Maybe this only works because of the location, blah, 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 blah. So we're trying to take all those factors out. And so I started taking me out of the equation. I started bringing some other doctors in. So it wasn't just me. Then I went to a totally different city to open a new location. In any event, so this sign back here, there's this aluminum sign, and I had made, because we had already had this deal set up. We were gonna, buy this property, and I had the signs already made. So as soon as we bought it, we could, get the signs put up and everything. And this was just the logo for part of a much bigger sign. And in any event, when they go do the surveying of this building, they find that the way that they built the building, something like 7 total linear feet of the building crossed the easement line or something like that. So when they built it, they screwed up basically. And so if the city ever decided, they needed to expand sewer access or whatever, technically they could claim that 7 feet of your building. Oh. And so, that negated the deal because you can't buy that. Basically, the first bank on that deal screwed up. They didn't check things properly. So I already had these signs made, and I couldn't use them for anything because, when we did go get, another place, the building was different, didn't take these types of signs. So I just had these things sitting in storage for years. And so, one of the signs, I stuck the logo on the wall. So that's where this thing came from.
I like it. I feel like it belongs there. Oh, that's great.
Yeah, it works pretty good. I had another one of these, and it was funny. The place, I ended up buying and getting one of these other logo signs. I ended up putting it on the wall, and each piece of aluminum has, I don't know, 5 or 6 little pins that go into the wall, and they give you this big template to put up on the wall, and you put them in by that. In any event, I'm installing this thing, and it's, I don't know, started in the night, probably finished at 2 a.m. or something. I swear to God, it was the last or second to the last drill for this template, and I hit a pipe. Right, I hit this little pipe, and man, there was water shooting out of the wall at this enormous pressure, and so I'm just like, oh my God. So I'm searching this building looking for the water valve cutoff at 2 a.m. And for whatever reason, it struck me to go out to the street, and I found the water main to the building out at the street. So I turn off the water to the entire building. And then literally, all the businesses in that building were opening, that morning. So we go to Home Depot at 5 a.m. because this was this big Home Depot that opened really early. Buy a blowtorch, cut a giant hole in the wall. And, I'm here, trying to repair this copper pipe and not set the building on fire. And I get the pipe patched up to where, I can go back, turn the water on literally right as all these other businesses are opening. And that patched up the wall and was able to hang the rest of the sign up minus that one pin. Yeah, that was the story behind the sister sign of this at the other location. It had a freaking pipe busted, shooting water at, whatever PSI. It was enough to literally, blast across the hall. And that was not fun.
You hit the descending palatine in the wall, it sounds like, over there.
Yeah, definitely. It would have been bad if that was a vessel. That would have been a big bleed for sure.
Geez, did you have to work that next day after the whole 5 a.m. repairing the pipes and?
Yeah.
Man, oh, that's awful.
Yeah, but you had so much adrenaline running because you're just like, oh my God, we've been
gotta fix this.
Trying to fix this stupid thing all night. So that was the least of our concerns.
Yeah, that one wasn't the San Antonio one, or was that one also in San Antonio? This was another one, or?
Yeah, this was a different building in San Antonio.
But it was San Antonio. Okay.
Yeah, so that's where, this sign, came from. Was basically, they were made for the first building we couldn't use. So we, had this gigantic aluminum sign that, it was fairly expensive. I mean, I don't know. I think the sign was like $25,000 or something like that. And because they were big, and everything's cut out of, this big thick aluminum,
Customized too, yeah.
and it's just sitting in storage. So I'm like, well, at least hang it on the wall, do something, and better than just sitting in storage.
Oh my goodness, yeah. I mean, that's an arch right there. And so you ended up selling, how many did you end up just having the two offices for the implant centers, or was it more after that before you ended up selling 5 years ago or so?
And I've done all kinds of stuff. I tell you what, I had, I had started the very first online dental journal in the dental industry, back in
Really?
back in 2008. My colleague and I, is named Nick Toscano, he's out in New York. We started the first online dental journal, and it was Journal of Implant and Advanced Clinical Dentistry. And, at that time, this is seven. Everyone's like, online journal won't work. No one's going to read an online journal. People want to hold it in their hands. And, we ended up selling the journal 3 years later. And, now everything's online. So
Yeah.
I had that. I had a bunch of different dental offices. I had a friggin' FedEx truck route, with 18 wheelers, a line haul route.
When was this? When was this?
This was during the, I don't know, 2000 teens. Had bought a couple of, like, you see all the FedEx trucks on the road.
Yeah.
Well, you can buy routes. So for example, I had bought a couple of routes from Houston to Dallas. And so you have a line haul truck, and it's FedEx ground. And basically every single night they just they go to the FedEx warehouse, load up the truck, drive it from the FedEx warehouse in Dallas and drop it off at the FedEx warehouse in Houston. And then they pick up another shipment in Houston and drive it back to Dallas. That was, totally different type of business,
Very different, yeah.
and, just having a couple side businesses, and, you're having to deal with a whole other set of problems, friggin' engines blowing and transmissions dropping and tires blowing and, drivers and all kinds of other stuff.
Did you have a partner in that, or was that just you?
Well, obviously I wasn't driving the truck. I just
Oh
owned the
yeah.
routes. No, no.
But when you own the route, did you own it on your own, or did you own it with someone, or?
No, no, I owned it on my own. So,
Hmm.
So I had, just a number of truck drivers that would drive for me and, go back and forth on the routes.
Yeah.
So, couple, couple variations of things, this, always good to have a couple different irons in the fire,
For sure. What are some of the things you're looking at right now, in addition to what you're currently doing? Because you're traveling a lot. I feel like that would pull you from these other side projects, if you have any right now.
you know, projects. Well, I had actually, a little side project. I wrote a book on dentures for patients, not for doctors. It's basically, a book answering questions, the top 50 questions denture patients have. And
Pretty good.
it was interesting because when I was, one of the chief clinical officers at the last corporation I was at, they did a lot of dentures, and, got to see a lot of different denture patients. And, there really wasn't anything that answered their questions. And a lot of them were, going to Facebook groups and having to ask each other these questions. And 99% of the answers they give each other are wrong.
Wrong. You're wrong, yeah.
So, so I did that, and, that's kind of nice. And I purposely made the book as inexpensive as possible, just so, they could buy it and have answers to questions.
Recently, this is in the last 3 years, I would imagine.
No, this is
4
like
years.
just a few months ago.
Who knows? Oh, but you said this is the last organization you were with, or is it with this current one?
Yeah, it was the last organization when that I was with, the one that I had left during this past year.
Yes.
And but we do all these, big awesome cases, and, it's really nice, but, there's still, millions and millions of people, tens of millions of people, they can't afford it, and, they'll never be able to get this type of treatment done, but they still need help. And so, if you're like asking, what would be kind of next on the horizon, it'd probably be something like, starting up some type of nonprofit to help, some of these people be able to get some treatment, in an
Mm,
actual real nonprofit, not a training center where, we're doing, courses and have people come in to make, it'd be literally this is just a regular old nonprofit for people that can't afford it. They come there, they can get treatment done, and it could be a denture, it could be, you know, Zygos, just, all that would depend on, I guess what type of funding you could get for it, if you're able to get, grants for it, um, you know, that type of thing. As a matter of fact, my old office is the corporation that bought it basically have pulled out and shut the office down. And it's
really?
yeah, so it's
Available?
they gave the fixed arch world a try, and it doesn't really fit with their goal and vision, I don't think anymore. I'm not privy to all the inside information in the company anymore, but
Yeah, yeah.
my old location, is now vacant. So I've got this building in Austin, Texas, and it's fairly small. It's got 3 ops, but the interesting thing is it's fully outfitted. It's got chairs, it's got vacuum, it's got air compressor, it's got a full field of view CAT scan machine, and I am either just going to sell it as a turnkey dental office. If somebody wants to move in, they could go to work right away. Or the alternative is, I could keep the thing and use it as a nonprofit, you know, place, and it's ready to go. I could, literally just start seeing people there,
Yeah.
tomorrow if we wanted to.
So you didn't fully sell it to them. You rented it out to them? Is that how you sold the business, but you kept the real estate of it, and now you still have the real estate, but they since have left?
Correct. Yes. So I kept all the real estate, and they were leasing it back.
Hmm.
When they move out, they just leave everything behind. So it's still so all that equipment got turned back over to me. I mean, hell, I'd love to step into an office that has everything there ready to go.
So you and I could be stepping into this thing in a couple months and slamming some Zygos in there.
Yeah, I mean, you know, I I couldn't go back into that particular location on a for profit basis, because I still have covenants, but a nonprofit type of thing, is different, so you know, that could be on the horizon, something like that. Who knows? Or maybe just go buy a McDonald's or something. I don't know. Make French fries.
This the world's your oyster. Yeah.
You
Hey,
know?
Dr. Holtzclaw, thanks for coming on tonight. I really appreciate it. It's been a while. I gotta start getting ready for work tomorrow. Thanks so much for.
Yeah.
I'm glad we got to connect. We got to chat a little bit. We got to do some more in the future too. I would really like that. But we hit on a lot of topics tonight. Thanks for teaching me and going through this with me. I appreciate you taking the time to sit down and chat. You know.
Yeah. Likewise. Thanks for having me on. It's these are always fun to do. Get to share information, just talk, and uh, sometimes the conversations end up going where you don't expect them to go, and
Yeah,
it's good.
that's the beauty of it. You know.
Yeah, yeah. It's good to hear some different sides of people, and but yeah, that is great, man. I appreciate it.
Thank you. Thank you. Yeah, I like to have a different twist. I mean, I hit you with a couple questions early, like, with all the moving around and traveling that you're doing. Are you happy doing it? Because it sounds like that just sounds like a lot for 300 days of the year. But it gives me a chance to get to know you and also kind of bring a twist. Like maybe I could get a question asked to you that you never have been asked before or something like that, you know?
Yeah, I mean, yeah, it's fun just having a normal conversation. It's a lot of times everything dental all the time.
Be a lot, right?
Yeah, you know, people do exist beyond dentistry.
I'd love to meet the people behind the mask too. I feel like a lot of things they want to hound you with so many technical questions and stuff. But one more question: all these places you've traveled and taught and this and that, where would you go back to? What was your favorite place, and where would you go back to? But not to work. You just appreciated the beauty of this location or the scenery or the food or the culture. Where's the next place you're going to go non-work related?
You know what's interesting? I been to many countries, and the one thing I find, a lot of the places that are really hyped up, at least for me, don't always seem to live up to the hype. And I kind of like the more off the beaten path places. I think I've liked them more. Like for example, I really liked Estonia. Was really nice. I was there in the summer. Probably a lot different in the winter. Um, you know, I really enjoyed it there. Croatia was super nice. We even popped over to Bosnia for a day, and that was, the part that we were at was really pretty. I don't know if, I guess you can go anywhere for a day and it's nice, but the part we were over there was really nice. Some of these places you don't really think about, but so I would say, I'd like to visit, I think I'd like to go to Georgia, would be, the country. I've heard it's supposed to be really nice. Just some more of these smaller, different places that probably don't pop up on everyone's list of places to go travel to, But in terms of food, I'd say most places I've enjoyed the food. It is interesting. Some countries seem like they have a lot less variety of food. You go to some of the places and they tend to eat the same 3 or 4 things over and over. And which is interesting. Just doesn't seem to be, people get tired of eating the same thing all the time. I think that's one different thing we've got in the States is, there's so many different types of food, from all different nationalities, and you kind of take it for granted. I mean, you can go out and you can get virtually any type of food, and you go to some countries and, if you wanted to get Asian food or Indian food, it's not really readily available. If you wanted to get American food overseas, it's usually god awful.
It's so bad, yeah.
First of all, it's nothing that we ever actually eat here. It's literally be something ridiculous, like a piece of cheese or a piece of pizza with a slice of American cheese or some weird thing on it. And you're like, yeah, I've never ever seen that, ever. But, it's the American style, or something like that. But yeah, I mean, I think the food has been all right for the most part. I think you try to go with the flow of wherever you're at, and make the best of it and open your mind. And a lot of times you try things and you end up really liking it. Just probably wouldn't have ever tried it, if you were back home.
That's a good point. Yeah. No, you're definitely right. American food in other places is not American food.
Yeah.
But yeah. Well, yeah, Dr. Holtzclaw, thanks again, man. This was great. This was a really great chat, and I can't thank you enough for coming on. Well, if you don't mind, I would love to do it again sometime.
Yeah.
Couple months, we'll push it out, maybe 6 months to a year. But yeah, this was fun.
Yeah, that'd be great. Yeah.
Go from there. You'll tell me how you beat the record next year of how many days you traveled. I know you're saying you're cutting back. I'm predicting it's going to be
I hope so. Yeah, I definitely don't plan on doing that. If I do, then something went wrong. Something went wrong. Yeah, for sure.
Hopefully not, though. Hopefully not, though. It's going to be a good year.
Yeah, man. Well, thanks. I know you got to work tomorrow. So
yeah.
And you're an hour ahead, so it's getting late where you're at.
It's getting pretty late. If you could do me a favor and just wait like 10 seconds, I'm going to hit end now, and then 10 seconds, it just uploads to 100%. You'll see there's like a line that goes 100.
Sounds good.
Have a good night. Happy holidays, and I'll talk to you soon.
All right, man. Thanks. I appreciate you having me on. It's great meeting you and chatting with you.
You too. Thank you.
All right, man. Thanks, Brendan. Have a good one.